Hi, everyone, and welcome to the Trial Site News podcast series. I'm Dr. Erin, your host. Thank you so much for joining in today. And today we have a very special guest, Dr. Denise Fossman, and she leads the immunobiology lab at Mass General Hospital and Harvard Medical School. And we are going to be chatting about her research on the BCG vaccine, which some of you might know is given for tuberculosis. But we're going to talk about how it relates to COVID-19 in type 1 diabetic patients. So, Dr. Fossman, thank you so much for joining in today.
Well, thank you for inviting me.
Yes, absolutely. Your paper's very interesting, very timely stuff. Before we dive into that, do you mind just telling us a little bit about you and the work that your lab does?
Oh, okay. I thought you were going to ask about BCG because, I don't know who your audience is, but a lot of people in the US, including doctors, really don't know what BCG is.
That's my second question.
Oh, that's your second question. Okay. So I'm here at Mass General Hospital and Harvard Med School, and we do really hardcore basic science, and then we translate all the way to like phase 2 and phase 3 clinical trials, all within academia. And the reason and the motivation to do that is when you're working with affordable 125-year-old generic drug, you're probably only going to be able to do these large clinical trials and try to get it to market within academia. So that's kind of the fun we have at doing these formal trials and testing these hypotheses. And usually the audience we work on is type 1 diabetics, the people who have the autoimmunity. But globally, there are many, many trials using this vaccine for all sorts of diseases, for infectious diseases, for autoimmunity. There's phase 3 trials in multiple sclerosis in Italy, for allergies, many allergy trials, on and on. So it's quite broadly used in clinical trial formats right now. So it's a pretty exciting time for this old vaccine.
All right. So second question is about this.
What is BCG?
BCG. Okay. Well, so for our viewers, that just so they know, the name of your paper published in Cell Reports Medicine was titled Multiple BCG Vaccinations for Prevention of COVID-19 and Other Infectious Diseases in Type 1 Diabetes. It was a randomized, double-blind, placebo-controlled study, and it was done in an at-risk population. So what is the BCG vaccine? What's the history of it and the safety profile?
Yeah. So Americans are very naive on this vaccine. And people even thought I worked for the Boston Consulting Group, not BCG vaccine. And we haven't heard of it. We haven't heard of it in the US because it's never been licensed as a vaccine in the US. Okay. So it was developed 125 years ago at the Pasteur Institute in France. And it was the first vaccine for tuberculosis. And it's actually the most continuously used vaccine in the history of the world. About 3 to 4 billion people have been vaccinated with this vaccine. And last year alone, over 120 million newborns were vaccinated with this vaccine. So talk about a medication where we know the safety profile. And it's heralded by the WHO as the safest vaccine ever created in the history of the world. So what's really unusual is what countries don't get this vaccine. And as you see, as we go through this chat, the really exciting news about this 125-year-old bacterium, it's actually, here's the interesting story. So what is it? Is it TB? No, it's the strain of tuberculosis that cows have. So it's tuberculosis bovis. So how they made this vaccine, very high tech, they scraped the udders of TB infected cows and then cultured the TB to become avirulent as a vaccine to protect cows from tuberculosis and protect people. So it's the oldest organism as a live vaccine in continuous production. But importantly, from an evolutionary perspective, this organism is found in Neanderthal DNA. So we as humans and we as Neanderthals co-evolved with this organism. It's only in the last 50 to 100 years that we've cleaned up our environment so much that if I sampled your bone marrow today, there wouldn't be a tracing of this organism living in a symbiotic relationship. So that's how all this research got started with different driving forces globally, realizing this vaccine had other benefits by this syngeneic relationship that was disrupted by cleaner environments.
That's very interesting. So there's been you've already been doing studies with this vaccine and with type 1 diabetes. And then when COVID happened, it looked like you had this opportunity to look at this research.
So I always have to give everybody credit who works on things. So we are definitely not the first group in the world to see that BCG, people vaccinated with BCG overall have less infections.
Right.
Okay. People have been studying that for 15 years. So it was noticed in trials in Africa, 15 years ago, that if they came in, two investigators, Peter Abbey and Christine Bennett, came in and followed kids at birth that were vaccinated with this and not, there was higher mortality in the kids not vaccinated. Not because they ever died of tuberculosis, but they died of viral infections, diarrheal infections, bacterial infections. So for about 15 years, people around the world have picked up that you have better immunity. You have improved. You have better immune responses if you've been vaccinated with this vaccine. Our particular interest has been how this microorganism changes your immune system to get better homeostasis in autoimmune diseases. But this benefit for infectious diseases was well known. So when COVID hit, okay, the $64 million question came up of, oh my gosh, is COVID if you get this vaccine, are you going to have less incidence of COVID? So, and we weren't the first one to think about it. Believe me, all my friends working on BCG around the world called me and said, Denise, you've got the perfect patient population. And why in the US do we have the perfect patient population? Well, people in the US are not vaccinated. We've never been vaccinated. Okay, so we are totally naive. And also in the US, we have almost no tuberculosis that's also protective from COVID. So we had already randomized, and type 1 diabetics, one of the most susceptible populations now in retrospect to morbidity or mortality from COVID. So we had a fully randomized, double-blinded, placebo-controlled 5-year trial into about year 2 when COVID hit. So of course, we ran to the FDA and said, we've got to do a parallel trial. We've got to look for these other outcomes related to COVID. And that's how this very important study in the US got done so rapidly.
I'm going to get into the study and the results, but can you elaborate a little bit on why the BCG vaccine is protective against other infectious diseases?
Yeah. So everybody's working on that. It does a lot of things. When you look at these off-target effects, you go like, why is it important in diabetes? Oh my gosh, why is it working in diabetes? Why is it important in multiple sclerosis? Why do we have trials here at Harvard Med School in Alzheimer's disease? Like it begins to be kind of magical in what you think about. But if you think about TB and how TB can live in your lung for 80 years, kind of dormant, with survival that's hard to get rid of this way, then you start to understand the off-target mechanisms. So one of the things that BCG does, or tuberculosis does when it gets in your lung, is it wants to live there and it doesn't want you to see it. So the first thing it does is induce these suppressor cells called Tregs. Okay? And Tregs are the same cells that cancers induce to prevent immune recognition. So by inducing these Tregs, well, you can say, well, that would be really beneficial if it went systemic for autoimmunity. It'd also be very beneficial for the, cytokine storm that COVID induces. Okay. Now, the other thing that the tuberculosis granuloma does that people have known for a long time is these microorganisms that infect predominantly monocytes are lazy, right? They don't want to turn on too many genes. In fact, they don't even have many genes. So the first thing they do is change the metabolism of the host cells. So now they eat sugar. They exclusively eat sugar. So they turn cells that are not doing metabolism through sugar into sugar-eating cells. Well, in Alzheimer's and multiple sclerosis, some of the first lesions in the brain are cells that are not transporting sugar, and then they subsequently die. In diabetes, it'd be great to have the second largest organ system to start eating sugar instead of fats. So, and then in the infectious disease things, it changes the B cells to be more responsive. It changes the T cells to be more responsive. So you start to, it almost seems magical when you see all this trial data around the world of like, why is it conferring these human benefits? But I think if you go back to coevolution, you start to see it. But if you get down to the mechanism, and we're still learning the mechanism of this, you start to understand why, if you have this organism, you have a superior immune system in all sorts of ways. So that's the kind of 101 immunology.
Yeah, no, that was great. Great. The theory there. So this trial was for 15 months. Yes. Okay, so January 2020 to April 2021. So this is before, just to remind our viewers, this is before the COVID vaccine. No one had, okay, so no one had the COVID vaccine. And the one group had 3 shots of the BCG vaccine, and then there was the placebo group. Mm-hmm. And you were comparing them for cases of COVID-19. Mm-hmm. So before we jump into the results, how did you define a COVID-19 case?
Yeah. So, of course, we went to the FDA and asked them how they defined it. We read something called FDA guidance. And for all the big trials you're seeing out there, it's symptomatic COVID confirmed by molecular diagnosis or serology. Now, when we started this trial, as you know, it took a long time in the US to roll out diagnostics, right?
Yes.
But the beautiful thing was we were doing 3 to 6 months serum collections on all these people for the 2.5 years before COVID hit. And we continued all those serum collections every 2, 3, 6 months after COVID hit. So we had unbelievable banks of serum to look for antibodies to COVID. So that was our primary outcome, that 5 of 8 spike protein antibodies had to be positive against the COVID virus to say you had symptoms based on the FDA guidance of what the symptoms were. They could be graded. How many days you missed work, was it a runny nose, lost a taste, and how long did that last? And then combined with molecularly confirmed. We also combined that with PCR testing once it became available, but even that was spotty at the beginning. So we really wanted to nail it that they had symptoms and had COVID. Yeah.
And just so I want to make sure this is abundantly clear to our listeners, they received these shots 2 years prior to the pandemic, right? And that's because that timeline's important.
It is really important. It's a really good point you make. When you use the word vaccine, and if people on the line are infectious disease people, or even if they're physicians, they go, oh, you get the vaccine, and whether it's tetanus or flu or COVID, maybe in 4 weeks, if I get exposed, I'll be okay. Maybe 6 weeks, I should be okay. And now we all know maybe after 4 months, not so okay, because the virus mutates. And
it does.
Okay. Now we're going to use the word vaccine in a very different way. So for these off-target effects, remember, these are not antigen-specific effects. I mean, the BCG bug has no genomic overlap with COVID. It has no genomic overlap with pneumonia, but yet it protects you. We all know from studying, so this is kind of infectious disease trials a la autoimmunity, how we failed in autoimmune trials early using this vaccine, whether it was in multiple sclerosis or diabetes, was the kind of idea we give a vaccine and it should protect in short order. in adults, we're very convinced from all our failures. You don't talk about your failures early on, but it takes a couple years for this vaccine to confer this heightened immunity. That heightened immunity may last your entire lifespan, okay? But it takes a couple years. So we like to call it kind of long immunity. It takes a long time to kick in, but then it lasts a long time for this multi-organism protection. So our trial had people that were vaccinated 2 years out. So at that point, we thought they should have protective immunity from a new exposure.
Okay, so when you looked at how many COVID cases are showing up in the BCG vaccinated group versus placebo group, what did you guys find?
Yeah, so we got efficacy similar to Pfizer and Moderna, 93% efficacy. We had one case in the BCG cohort, and by our definition of confirmed, we had 13 cases in the placebo group, but that was a 2-to-1 randomization. So the numbers are much more protective. It's actually like 1 in 20, the difference in protection, but the enrollment numbers was a 2-to-1 randomization. That was an exposure to 2 different variants of COVID during that long time period. Yeah.
And how many people were in your trial altogether?
Yeah, so it was 144 people highly susceptible to COVID, studied over a 15 months period of time. So it's the incidence is actually similar to the incidence being reported by the similar trials by Moderna and Pfizer, but they get that incidence by enrolling many more people over a very short time period. So this trial is unique in running a much longer time period with lower number of cohorts to get those same kind of efficacy calculations.
All right, so let's look at infectious disease symptoms in general. Overall. Yeah.
So obviously we track, because of the work of so many other people globally, in all our trials, every time we have a patient encounter, we go, oh, have you been on any antibiotics? Have you been sick? Have you had sinusitis? Have you had pneumonia? Have you had yeast infections, et cetera. We go through the list. So all along we were collecting infectious disease events because we thought that was important to read out. Diabetics, type 1 diabetics are one of the populations most highly susceptible to infectious diseases lifelong, much more so than even type 2. So now if you look at the recent data on COVID, they're hit hardest by COVID in the US, much more so than even type 2s. And once they get vaccinated, they're not very protected from the traditional vaccines. So we had, unlike the healthcare worker trials of susceptible people, but normal immune systems, we had a highly susceptible population. We were going in with these vaccines to see if we could see a difference in protection.
Okay, and I just want to go back to that timeline issue again, and correct me if I'm wrong, but you looked at the pre-trial difference and there was not a statistically significant difference, but there was afterwards when those 2 years or so passed. Okay.
So this study again shows, so for COVID, by the time COVID hit, they were protected. But remember, they were 2 years already into vaccines when COVID hit.
Right.
So we looked at the data. It's still blinded and analyzed by a third party, but we looked at the data. So it's the global we. Looked at the data. Statisticians looked at the data in year 1 and said, well, maybe for infectious diseases in these cohorts, they had less overall infections year 1. Nope, nothing statistically significant. Year 2, now up to 3 vaccines by the end of year 2. Were they protected from infectious diseases? And the answer is no. But by year 3, highly protected for a diversity of infectious diseases, more so protected in year 4 and more so protected in year 5, including protection from COVID. So really confirmation of many people's global data of the platform of this vaccine's ability to protect from a variety of different infections that can inflict humans.
And so just from a practical point of view, if somebody is thinking, oh, I could run out the door today and get the BCG vaccine, that's not going to.
It's not going to protect them from going to a wedding next weekend.
From it won't, it won't protect them from COVID.
It won't protect them from COVID or pneumonia.
Or any,
you have to wait 2 years for them to get married.
Okay, I just want to make that point. But the people who might see this benefit are those people, who had to get this vaccine. It was part of their, it was part of the country's routine vaccinations when they were young, your newborns or whatever, and they probably have this protection.
That's right. So when COVID hit, everybody went out to do epidemiology studies right away, right? And of course, like most epidemiology studies, unlike randomized trials, there's the stack of papers that say it's protective in adulthood and protective, of 80-year-olds, right? But from a vaccine at birth. And then there's other studies that came out from an epidemiological viewpoint in other global populations that, no, we don't see protection. So what might be those differences? Well, the other thing that influences BCG is what strain of BCG it is, okay? So BCG's been around for 125 years. It's an organism. It grows. It mutates. So the Indian strain of BCG is different than the Japanese strain, and the Japanese strain is different than like one of the strains that we commonly use for bladder cancer. And it's different than the Russian strain. So the other thing people that work on these off-target effects, as well as people work in TB, are aware of is there are strain differences in the effectiveness. And also in some populations in childhood, you get 3 vaccines. In other populations, you get 1 vaccine at age 8. So not all data is equivalent. And for all our trials, we always give at least 3 vaccines typically to adults to get the immunity totally adjusted.
Okay, you gave me a good segue there to one of the questions I had.
Okay.
About the strain.
I'm not cheating. I can't see your question.
I know. I feel like you are. I feel like you didn't. She didn't have the questions ahead of time, by the way. So this was. You use the strain Tokyo 172. Am I saying?
Yeah.
Is that?
Yeah.
Oh, okay. Can you tell us why you chose that strain?
That strain, in our opinion, okay, so then science has opinions. That strain is one of the strains that we think is the most potent in the world, okay? And you say, is there any recent data to support that? Well, now that COVID's been around for about 2 years, 2.5 years, you can retrospectively say what country in the world had the least morbidity or mortality from COVID, okay? And that country's Japan. And the irony of Japan, of course, is it's one of the countries with the oldest population in the world. So now that's epidemiology data, right? But our data, as we try to model, we know some strains of BCG, we can't even get them to work in a mouse, okay? So if you can't get it to work in a mouse, why do you think it's ever going to work in a human? So I think as people try to look at these off-target effects, you have to keep coming back to the concept of what strain they used, how many doses did they give, and what was the time frame from the dosing to the time for protection. And those are critical variables that are going to really show as we move forward the secret sauce for getting this to work in the most efficacious way.
Okay, it's funny. You mentioned Japan. I looked up Japan after reading your paper.
Yeah.
And I was stumbling across articles on why did Japan respond to the pandemic so well? And I didn't see this mentioned. There was all different theories out there.
Yeah.
And I was like, oh, they didn't mention the TB vaccine.
Yeah. Dust.
Well, it was just interesting. It was like, there's this one factor that they haven't mentioned. So in the paper, you also compared the 2 groups to their non-diabetic household members.
Yes.
For, in terms of who got COVID infections, who didn't. Yeah, who got
what?
Who got
Actually, what? That's kind of an interesting gap. That was like, a tertiary objective in the trial.
Right.
But it's kind of fun that even in a trial of our size, if you looked at households where somebody was a placebo, got COVID, and then you looked at household members, the signal that came up was how sick the type 1 diabetics were. So even in a trial this tiny and 15 months long, you could prove and show the ravages of COVID in unvaccinated type 1 diabetic compared to family members who did not have type 1 diabetes. So it's people often think that type 1 diabetics have more infections, but the news on it is always a little bit less than it probably should be to pick up that signal. So then when you look at household members where they got BCG, they had type 1 diabetics, and everybody got COVID, well, again, the BCG vaccinated diabetic didn't get COVID, and their household members were sick. So you see the two extremes. It's not just like using BCG to protect a normal adult in the US. You're using BCG to protect somebody very vulnerable and get them to protection that's far superior to an unvaccinated person. Yeah.
Okay, 2 more questions if you have the time.
Okay.
So what research are you currently working on?
Okay. So we're always looking at off-target effects. In fact, this randomized trial is still going on for another year and a half. So we'll see the overall continuing signal in infectious disease protection. The primary outcome of the current trial in these diabetics is lowering of hemoglobin A1C. So that'll read out in about a year and a half. I don't know, publications always take a while to get accepted, maybe 2 years, but I'm hopeful that that'll be shared about a year and a half. But we're still going to be following this infectious disease signal that we got. Now, the data for COVID gets a little messier, and why it's so hard to do trials in COVID right now, because now everybody's vaccinated, right?
Sure.
They've had Moderna, they've had Pfizer, or they've had one Moderna and one Pfizer. And
makes it harder.
Yeah, it makes it harder. But for the overall infectious disease protection, we should be able to see that become more cumulative as we move along in these cohorts. So that's our primary thing, to get to the end of the big trial.
Great. So final question here.
Yeah.
I was thinking, what are the public health implications of this research like it? We're both in the US, and most of us don't have the TB vaccine unless we were traveling or something like that. So but this is a very, very cheap, easily affordable vaccine too. Yeah. But what are the broader public health implications, research implications?
I always say I'm not smart enough or wise enough to get into public health. But the trials we do are as expensive as anybody else's trial. I mean, they're randomized, double-blinded, placebo-controlled trials, and they have lots of oversight and the same costs as regular trials. It turns out that in the United States, there's no approved vaccine. So you actually cannot run to the pharmacy. I get these emails all the time of like, oh, my doctor wrote me a prescription for BCG, but I can't find a pharmacy that has it. Well, it's not available. So one of the goals of this program is certainly in type 1 diabetes, get this drug approved. So it could be used hopefully for hemoglobin A1C, but maybe also infectious disease protection as well. Because, if it's not COVID, it's monkeypox. If it's not monkeypox, it's some bacterial infection going on in Oklahoma. So we're not out of the tough part of our lives thinking this is the only pandemic. There's going to be more pandemics. And I think the COVID pandemic taught the US that we have amazing healthcare. We also have amazing susceptibility to infections, like probably no place else in the world. So we should be using this as an opportunity to focus on why we have such lousy immune responses to infectious diseases. And then other places in the world where the healthcare is more limited didn't have the ravages we saw in the US. So that's the big public health question. It's way beyond my pay grade to say, I'm going to manufacture this and we're going to have it, and it can be a vaccine when you want it on the I mean,
it was a creative question just to see how.
Yeah, nobody's come through that door and offered me like Moderna, $3 billion for a manufacturing plant. I'm still waiting for the knock on the door, but nobody's done it yet. So,
yeah. Well, maybe after this podcast, who knows? Who knows?
Yeah.
Anyways, thank you so much, Dr. Fossman. It was very interesting. I wish you a lot of luck with your research. Please come back on the Trial Site podcast anytime. Very interesting.
More updates. And now the phone's going to ring off the hook. How do I get some BCG? Do you have it in your refrigerator? I'm not bribable, everybody.
Hey, guys, don't call her. Don't call her. She's busy doing her research.
Yeah, exactly. But so nice meeting you.
Nice meeting you as well. And thank you to our viewers for tuning in, and hopefully we'll see you here next time.